local news, politics, business, sports, arts, music. Mike and Marty on the feed. Mike and Marty. Mike and Marty on the feed. Mike and Marty. Mike and Marty on the feed. Mike and Marty.
Good morning, Bellows Falls and Keene, and welcome to the feed. It's Mike and Marty. We're here today with Dr. Thusitha Cotter from Springfield Hospital. She has her practice there. We're going to be talking about fibroids and Fibroid Awareness Month. Welcome, Dr. Cotter.
Thank you.
Guess we're ready to go?
I guess, yeah, because normally we cut to local events, but this is kind of a special edition of the feed, so I'm not going to do local events today. But I guess the local event is July is Fibroid Month.
Yes.
But let's backtrack a little bit and tell us a little bit about yourself and how you ended up in Springfield, Vermont.
So my name is Thusitha Cotter, and I'm actually originally from Grand Falls, Newfoundland, which is where I grew up in Canada. And I went to school in Canada, went to medical school in Canada, and I actually met my husband there, who is an American, who was up there going to school at the same time. And then I moved down to the States once we decided that we were getting married, and then I've stayed in the States ever since. I did my residency for OBGYN at Dartmouth Hitchcock, and then from there I went to the Mayo Clinic and then to Maine Med in Mercy. And then I was at the University of Illinois at Peoria as a teaching physician. And I taught residents in OBGYN. And we moved back to this area to be closer to our family. And we've been in Vermont for quite a while now. And I started at Springfield Hospital when I joined my friend, Dr. Balcom, who has been here for about 2.5 years or so. And we've started to just rejuvenate the practice of gynecology at Springfield.
Mm-hmm. So historically, though, gynecology was prevalent, or it was a large practice, right? In Springfield?
Yes. So from what I've looked at, prior to us starting, Springfield Gynecology or Springfield Obstetrics and Gynecology had quite a big practice with about 5 physicians altogether, and they were doing the full gamut of obstetrics and gynecology. And now it is solely a gynecology practice. And we have the 2 of us who are the 2 providers, and then a number of medical assistants and surgical coordinators. And we're very well tied in with the urology service at Springfield because we also provide urogynecology care for women who have issues with prolapse, incontinence, and things like that.
Wow.
All the fun things that happen when you get older. So
But there are ways.
It's looking for that.
But there are ways to fix some of those problems now.
That's a good thing. That's a very good thing. So, so you didn't really have to build the practice exactly from scratch, but kind of, right?
Yeah. So I think when we started off in the practice, there had been a transition time when there were several locums providers, and they did a fantastic job, but it was just hard to have a consistent patient population because the provider would then leave and somebody new would come up. And I also think it was probably challenging to do operating room cases successfully because the providers would be different each time. So now it's been an absolute treat to work in this site because Dr. Balcom and myself do all of our major procedures together. And the team really understands the way we work together, plus the equipment, the things that we use, and we seem to have the same gynecology service line together. So I have to say it's been a really great experience working in the operating room at Springfield.
Right, because that consistency makes a huge difference, doesn't it? I mean, that's one of the things we see now is that everything's switching all the time, and it makes it difficult, at least from the patient's perspective, to really understand that, and that you could be consistent, and that your team works together. You're bound to be better.
Yeah, I think that has been a huge factor because from the minute the patient comes into the office, the team that helps them schedule procedures and then walks them through down to the operating room, plus the team that's working in the anesthesia. All of those team members have stayed consistent for all the 3 years that we've been there.
And I think that's huge. And I think that's, I mean, you definitely want your doctor, you want consistency with your doctor. And I think especially in gynecology, I think that's especially important for women. I also think it's a definite strength of Springfield Hospital in general is that that feeling of you know the patient. The patient isn't just a number, isn't just there. I know when you were saying that the team that walks you down, the anesthesiologist, all that type thing, I was thinking back to having colonoscopies at Springfield Hospital. And even though you have them years apart, going and that's the same operating nurse that was here last time. So I think that's very. I think with healthcare and feeling comfortable and confident, that's important.
Yeah,
and that's good. That's good to hear. In that case.
And like you said, I have noticed people will say, like when they'll meet the anesthesia staff, they'll be like, oh, that's the same person who did something for my family member. So they immediately feel comfortable with that.
And what's the range? Like what besides, what do you offer, like right from basic pelvic exams right up through to needing prolapse? What is the range of everything that you offer in the practice?
We certainly provide like the full service of gynecological practice. Like we see, I suppose if we want to look at it that way, like we see women for preventative visits and annual GYN care, which really is very important to allow people to come in on an annual basis for visits. As practices have become more and more busy, those visits have sometimes been pushed out to 3 years or even 5 years. And that's really based on pap smear screening, but it's not based on an annual gynecology visit. Where doing an exact exam, a physical exam, a pelvic exam, or a breast exam really should be happening every year. The pap smear can go to every 3 to 5 years.
Interesting.
But having women not come in every year is difficult because then you can miss some diagnoses. So that's one thing. So certainly the annual GYN visit, which is considered preventative care. And then problem visits, which are really important in women. We find that especially with problems in menstrual cycle regulation or pelvic pain or even changes that a woman will experience, women tend to downplay these symptoms for years. So a lot of times if a woman comes into my office with a problem, then I know right away there is a problem. So that's where sort of the discussion begins. I'm not going to be someone who says, oh, let's try and normalize what's going on. Because, truly menstrual cycle things, the menstrual cycle is considered the 5th vital sign. So if a woman recognizes that something is amiss, then they're probably correct.
Wow.
And
I
there is
have
something
never
wrong.
heard that.
Yeah.
Wow. We learn something new every day on the feed. I love it. Yeah. I start taking notes. So one of the problems that I'm sure everyone comes to you for is fibroids.
Yes. So the diagnosis of fibroids is a little bit different because sometimes women will come with heavy menstrual bleeding or a change in their menstrual pattern, or they'll come in with a sensation of pelvic pain or back pain or discomfort during sexual intimacy. But a lot of those diagnoses can then end up becoming a fibroid. So we'll do an evaluation, and during an ultrasound or a pelvic exam even, you can get the diagnosis of a fibroid uterus. And then the question becomes, what do you tell people? How do they manage this based on what their symptoms are? And nowadays, there are a lot of options out there for symptomatic fibroids.
Just
go ahead.
what is a fibroid?
Oh, sure, yeah.
For
So
people who wouldn't know.
fibroids are smooth muscle masses that are within the uterus. They can be in the lining of the uterus, which is called the endometrium. And if they're in the lining, they can cause heavy bleeding. But they tend to be benign. And because there are these muscle masses inside the uterus, some of them have been there pretty much since the uterus was present in a woman.
Wow.
And over time, they tend to grow.
They grow. Yeah.
Exactly.
And they can be from being tiny to being huge.
Yes.
Right?
So fibroids can be, 1 centimeter or sub-centimeter in size, and some can grow up to 20 centimeters or more.
Wow.
It's just a matter of time.
A slide that shows like from a blueberry up through to an apple,
Like an
I think.
apple.
Yeah. So I'm a visual girl, so I like to have those visuals.
Yeah.
And so they can they be you said they can be present for a very long time before they start to cause symptoms? Can they be asymptomatic and not
So,
cause symptoms?
and that's an excellent question. So, the asymptomatic question is how many fibroids do you have and what is the size of them? And in the past, I think women felt a little bit deterred going to providers and talking about their fibroids because they would get an ultrasound and the ultrasound would say, oh, you have a 1 centimeter or a 3 centimeter fibroid, and that was considered to be small. But that has changed nowadays, and really you're looking globally at what is the mass of having these multiple lesions in the uterus.
Okay.
So it's not just having a fibroid that's 1 centimeter, 3 centimeters. What if you have 3 fibroids that are 3 centimeters?
Yeah.
So now you've gone from a uterus that's about the size of a fist, which is a normal size of a uterus, to a uterus that might be about the size of a basketball or something bigger. So that adds the volume and the bulk.
And that volume and that bulk, can be what causes the problems.
Yeah, so you can have symptoms and like heavier menstrual bleeding or changes in your menstrual pattern. Certainly people can have bulk symptoms, which are pressure, pelvic pain, discomfort with sexual activity, sometimes changes in their bladder function because there's something pressing against it. A lot of times people will present with changes in their bowel function because now they have some constipation or what we call obstipation, where it's more difficult for the stool to pass through because now you have a mass in there. So sometimes they'll even present with hip pain because it's lying on one side or the other, or back pain because it's heavier, so the uterus is tipped back and it's pressing on the lower spine. So there certainly can be a number of symptoms that women can present with.
And how prevalent is it? What percentage of women would present with fibroids?
So the number has gone up now. We used to think that it was a rarer percentage and more in sort of African American populations, Hispanic populations, but now probably almost 10% of women can have fibroids. Wow. And that number might even increase as ultrasound becomes more and more adept at looking at fibroids. And also now that we have more options for management. So, in the olden days, people used to wait until they got quite big and then they would seek help, or then a physician might have said, wow, this is big now, let's do something. But nowadays, you don't have to wait for things to get to 5 centimeters. You could have 3 of them that are all in that 2.5 to 3 centimeter range, which now, yes, it's bulky and now it's up to a bigger centimeter size, but we can treat things at smaller sizes.
Interesting.
And is ultrasound the gold standard for diagnosis? Is that the only?
So ultrasound is probably the quickest, easiest, safest, most reasonable option. The MRI is a really good view for fibroids because it really shows you the relationship to the uterus, where they're located in the uterus, but also the relationship to other structures in the abdomen.
Like would that be more appropriate if somebody were if they did suspect that back pain was related to a fibroid, with an MRI be a better way to determine that for sure? Or
sometimes we use MRI more to establish what the next step will be in management. So if somebody's looking at a surgical approach, then an MRI would be fantastic because then you could see exactly what the relationship is to other structures, like the bowel, like the ureter, like the bladder, all of those other things that are inside the abdomen with the fibroids.
So when you say management, is there an option to not have the fibroids removed? Or?
Yes. So management-wise, there are lots of options that are medications. Those can go from hormonal therapies to treatments that sort of suppress hormones and shrink fibroids. But there are a number of different medications out there. And there were ones that were only injectable forms, but now we have oral forms of those as well, which is fantastic. And that group of medications is called GnRH agonist-antagonist therapy, but that's now available in an oral medication as well, which has made it easier. As far as other approaches, there's a thing called uterine artery embolization, which is a procedure that radiologists do, and that has been around for a long time. And that's where they will place tiny little pledgets. They are sort of microplastic pledgets that go into the vessels of the fibroid and then coagulate the fibroid and shrink the mass of it.
Is it kind of like what they do to kidney stones, or
Little bit different. Okay. It's a technique that originally was used to sort of be a life-saving mechanism in large bleeding events, sort of a trauma, but it can be used for fibroids as well. There are other things out there. The older methods were things called myomectomies, where people would go in and either laparoscopically with tiny cameras or even with an open procedure, go in and remove the fibroids. And that is still being done and is an excellent technique. Sometimes women don't want that procedure because they don't want incisions on their abdomen, or they don't want incisions on the uterus. So then there are these newer approaches.
Is this a myth, or do fibroids shrink on their own ever?
So, excellent question. So after menopause, fibroids do shrink. And that is likely because the hormones are going away and you have less and less estrogen levels, and the fibroids will then lose their blood supply and start to shrink. Now, that's not always true. There's a slight chance, like 1 in 10,000 chance, that a fibroid might have a thing called a sarcoma, which is a uterine cancer. And that can then continue to grow even after menopause. And that's part of the reason why nowadays we like to know if women have fibroids. And it's not something where, oh, you have the diagnosis, this is what we'll do. Now, we won't see you back again. We really, we really should be following them. At least with imaging studies every 2 to 3 years or so, just to make sure that nothing is suddenly growing unexpectedly.
Can you tell us a little bit about the specific procedure that you guys do? You do a specific procedure?
So the procedure is called Thusitha, and it's a radio frequency ablation of fibroids. And the methodology behind it, it was started in 1999 by a Dr. Bruce Lee is his name, but he's the one who created the technology for it. The radiofrequency ablation technology was being used to treat liver cancers for many, many years before it was then brought to treating fibroids. So it has been around for a long time. And then Thusitha got FDA approved in 2012, and the company that we use, Hologic, bought the entire system in about 2020. And since then, what we've seen is a lot more women approaching us wanting to have the procedure performed. And the reason behind it is Thusitha can be used to treat and shrink fibroids that are even 1 centimeter in size. So you don't have to wait till things are 5 centimeters, etc. You can treat things fairly early. The other reason is the improvement that you would get with the shrinkage, and if your bulk symptoms and your pelvic pressure and those types of symptoms improve, the bleeding will improve as well. But you can have that done without getting bigger incisions on your abdomen.
I'm just fascinated that it seems like, and I think this is inherent sometimes in women's health, that there isn't a lot of information out there sometimes. Like, I had no idea the importance of monitoring them, that you've had. It seems like someone tells you you've had them and that's it, you can do this, but not that we should keep an eye on them per se. And I also think that just backtracking a little bit, what you mentioned about even when you get past a certain age, they say, oh, you don't have to have your PAP, but you still need to go in and be checked. And is it more typical or atypical that as you get older, that's when you have more risk for some of the cancers that they say the ones that have no symptoms, the uterine cancer, the endometrial cancer, those type cancers, do those happen? Maybe this isn't a statistic. Do they happen when you're younger or older? So statistically,
cancers, like many cancers, statistically they happen as you get older. And with uterine cancers, there can be some symptoms. So you might have the change in bleeding pattern or some bleeding after menopause, symptoms like that. And yes, you're right. Some of the onus is on the woman to sort of recognize that it's not normal and then come in for a visit. And that can be hard because, like you said, if people are not coming in for an annual visit every single year, then, there might have been something that was abnormal that could have been detected earlier. So I would say, I think providers are really trying to get better at listening to what women are telling them so that they can recognize that, she probably knows her menstrual cycle for years and years. And if there is a difference, then we should probably look into it. The other thing that's really nice nowadays is with having ultrasound and other imaging tools so easily available. Lots of times when people come in with heavy bleeding, we're not going to just throw medications at them. We'll try and find out why are they having the heavy bleeding. And something that's very frequently seen is a fibroid inside the uterus or a polyp inside the uterus, and that's something structural. So we are not throwing birth control pills at people or putting IUDs in people. If there's something structural, then there is a minimally invasive way to just remove that anatomy that's causing the problem so that you can sort of restore the woman back to health without simply treating with a medication.
And you're getting to the root cause versus just treating the symptom.
Yeah. And I think that's what a lot of women want. They really want to know, why is this happening? Why is there a change? And I have to say, like, frequently there is a root cause or a reason for why there has been a change.
And that's important because anytime you treat a symptom with a medication, there's always a side effect, right?
Yes.
That could cause something else. It's a chain reaction versus determining the root cause and removing that cause.
Yeah.
It seems a no-brainer to me, but
I know. Yeah.
but that's not always the way that medicine has proceeded. So.
And I do like that you mentioned that with the side effects, because before we had all these options, especially for fibroid treatments, the medications were not ideal. And women did have side effects from those medications. And then, the providers sort of felt bad because now, yes, your fibroids are showing some symptom relief and shrinking on imaging, but you feel awful. And that's just not a great, it's not a good lifestyle.
Yeah.
Well, it's like you've traded something for something else, but now there are options with imaging available and much more readily and locally available. And I know we had Haley on.
Yes.
So we know that you have the ability at Springfield Hospital to get patients in pretty quickly. How is that? We have about 2 minutes left, so
sure.
we'll go into
problem.
how people can reach you, and also how available, like how quickly can someone get in to see you? Say they were brand new, they've never been to you. How quickly can that happen?
So for new patient visits, I believe that we get those people in within about 2 weeks or so.
Oh, that's good.
So fairly quickly, and especially if there are problems, we do like to see people who are having problems with bleeding or pelvic pain and things like that sooner rather than later. A lot of times when these women come to appointments, they might have had symptoms for even 7 years before I see them. So we do try and get them in fairly quickly. The other nice thing about being at Springfield Springfield is the OR team has been very open to giving us additional time if we need it. So if there are women who are like, the summer is when I've got my time off and I want things done before I go here, or I've got a trip coming up, then I have found that they will give us open operative room time so that we can work around a woman's schedule.
Once again, a perk of a smaller hospital.
Yes.
So we're down to 1 minute. So gynecology suite is on level D.
Yes.
802-885-7561.
Yeah.
They can go, you can find more information on the Springfield Hospital website. And thank you so much.
No problem. Thank you.
I hope you all learned as much as I learned today. Definitely.
Thank you so much.
Don't wait 7 years.
That's right.
That's it for this. We'll see you next week on the feed.
My God, my